with my co-chairperson, Dr. Jayanta Jayatissa, past president of the college, who was also my supervisor, by the way, for my MD thesis. So it is indeed a privilege to share this stage with him. So with that, may I... So can you invite the first presenter? So the first presentation of the day, which we have 8 minutes for discussion and 8 minutes for presentation and 2 minutes for questioning. We can go up to 1 minute, don't worry. May I invite the paper authored by Pathirana PASR, a retrospective analysis of the symptom course in a telemedicine monitoring clinic for acute symptomatic COVID. Dr. Pathirana, over to you.
This is my study. Actually, first of all, I would like to thank Dr. Sunet Rajavasan, who has given me the opportunity of joining his telemedicine clinic, which was conducted through his family clinic. This was a retrospective analysis of the symptom course in a telemedicine monitoring clinic for acute symptomatic COVID-19. Background of the study. COVID-19 has brought large numbers of patients to medical attention within a span of months for care of a previously undescribed illness. Early reports on the presentation and natural history of COVID-19 appropriately focused attention on the severe cases and critically ill ones. Subsequent surveillance has demonstrated that the majority of patients have milder forms of illness. It is recommended that they remain at home under medical supervision. In August 2021, we established a virtual clinic through the family clinic and ODOC application for the care of patients in home isolation with COVID-19. All patients were assessed by myself with regards to COVID-19 symptoms using a standardized clinical note which includes past medical history, drug history, and allergic history. Patients were followed for symptom management with regular telephone calls twice daily by myself until improvement or hospitalization. The current study is to analyze the complete symptom reporting for the study cohort. Previous studies showed that median duration to viral shedding was 19 and 24 days in patients with severe disease and critical disease status. Median duration to viral shedding was 7 days for both asymptomatic and mild symptomatic patients. Viral load detected in asymptomatic and symptomatic patients was similar. 34.6% of COVID-19 patients were asymptomatic. Some asymptomatic patients also had abnormal CT imaging features. Patients with mild symptoms, cough was the most common symptom. It was 55.6%. Severe asymptomatic patients, fever was found to be the most common symptom. Bilateral pneumonia in 75% of patients who had severe pneumonia. Objective of this study was to describe the disease history in a group of COVID-19 patients and assess characteristics that predict symptom duration. This was a retrospective study of the patient who are followed up through the telemedicine clinic via the family clinic and through the ODOC app. The study was a retrospective cohort study conducted at the family clinic and the patients followed up via ODOC, telemedicine app. 141 patients with COVID-19 from 26th of August 2021 to 17th of April 2022. Followed up for either 14 days period or 7 days period based on the existing knowledge for assessment and treatment guidelines. The diagnosis of COVID-19 was done by nasopharyngeal PCR and the patients requested a home isolation were included in the study. Patients were monitored through audio consultations twice daily for consecutive 14 days or 7 days later on with the changing of the quarantine guidelines. I have broken down the symptoms with mild, moderate and severe and categorized into mild, moderate and severe. Mild were with respiratory symptoms, cough, sputum production, and systemic features were fever, chills, malaise, myalgia, anorexia, diarrhea, vomiting and headache. Moderate symptoms were with respiratory symptoms, severe cough, dyspnea on exertion, wheezing or sensation of mild chest tightness. And severe included the resting dyspnea, labored breathing, resting pulse oximetry with less than 92%, pleuritic pain or hemoptysis. And systemic symptoms were acute confusion, severe weakness, syncope, acute decline in functional status. Documentation of specific COVID-19 symptoms including onset and offset dates, patient reported date and symptom severity, and documentation of specific medical conditions, comorbidities associated with risk of severe COVID-19. Demographic data such as age, gender and address was documented. According to the symptoms according to the COVID-19 symptoms, I have categorized into upper respiratory, cough, congestion, sore throat, loss of smell or taste. Systemic symptoms were fever, body aches, chills, dizziness, headache and joint pain. And lower respiratory, shortness SOB with exertion, SOB at rest, chest tightness and wheezing. Gastrointestinal symptoms were nausea, abdominal pain and diarrhea. Results of my 141 cases, ages were ranged from 1.5 years to 78 years with a mean age of 42 years. Total 142 cases were followed up and one patient was excluded due to hospitalization due to severe symptoms. Gender distribution showed that 54% were males and 46% were females. Age distribution showed that 47% were between 36 to 45 years of age, which is a majority, and 42 being the mean age. Minority was with 8% was between 46 to 55 years of age. Mean number of days from symptom onset to carry out PCR or RAT was 2 days. Follow-up was done twice daily for 2 weeks initially and then twice daily for 1 week in the latter part according to government quarantine guidelines. Only 2 patients had severe symptoms and were hospitalized. The 2 patients were suffering from chronic asthma. The comorbidities among the 141 patients were 12 patients were with age was more than 60 years of age, and 2 patients were with smoking addiction, 21 patients were with asthma, and 1 with liver failure and awaiting liver transplant. 2 were confirmed pregnant, and 1 was with 33 weeks of pregnancy and the other one was around 20 weeks of pregnancy. 5 were with diabetes, 7 were with hypertension, and 1 with obesity, which is more than 30 kg M-2. And according to the symptom analysis, most of the patients were having fever, which is 87.23%, and body aches was 64.53%, and cough is 61%, sore throat is with 56%, and loss of smell or taste was with 41.13%, and nasal congestion was complaining by 44.68%. The patients present with upper respiratory tract symptoms during day 1 and followed by lower respiratory symptoms during day 3 to 4 and GIT symptoms during 4 to 5 days. Most of the patients were complaining of cough with sputum, that was around 61.7%, and it lasted for a longer duration than expected, around 21 days. The symptoms which was unresolved at the final audio consultation was cough with sputum, which is 29.78%, and mostly being the known patients with asthma, which is 10.6%, and loss of taste and smell were complaining by 10.6%. Overall symptoms were reduced with the COVID-19 vaccination. My conclusion is the coronavirus in patients follows a systemic symptom to lower respiratory tract symptoms, and initial symptom severity may predict the duration of the disease. These were my references. Thank you.
Thank you, Dr. Patriana. The paper is now open for discussion. You have about 1 minute 30 seconds left. Can I ask you a question? In that audio consultation you did, were the standard questions asked from all patients, or did it vary from patient to patient?
No, sir. It was standard questions asked from all the patients.
Any other questions?
Yeah. The topic retrospective analysis of the symptoms and the methodology or the study design is given as descriptive, not retrospective study. There are various forms of retrospective study. It would have been nice if you mentioned is a descriptive retrospective study. That's one.
Okay, sir.
Another observation, you have given the mean
Age.
percentages, but the one important thing, confidence intervals are not mentioned. It is very important, right? Confidence interval for each percentage. And I also observed that you have used the term smoke addiction. How did you detect whether they were addicted or not?
Actually, it was like this, sir, when that those two patients were from ODOC app, and even their mothers were talking to me like they are chain smokers, and because of that, the mothers were even asking me to tell their sons that not to smoke anymore because the COVID-19 symptoms.
Okay, how many people are there, the smokers among the...
Two, sir. Only
some?
two were.
Only two?
Yes, sir. Smoking addiction.
So you could
like
have just
smokers.
said smokers. Smoking. Habit, it's a habit, you know.
Yes, sir.
Addiction, it's a task to diagnose addiction, right?
Okay.
Especially in a
That was due
audio.
to, I used that term just because they were chain smokers, sir.
Yeah, that is
Yes, sir.
different, but right? Okay. You got to be careful in a research paper when you use terms like addiction.
Yes,
right?
sir.
Okay. Thank you.
Thank you very much, Dr. Patriana. Shall we show our appreciation in the next presentation will be exploration of the timing of deliberate self-poisoning presenting to primary care institutions in rural agricultural Sri Lanka. The paper is authored by Pushpakumara PhD and Dawson Andrew, and the paper will be presented by Pushpakumara PhD. Over to you, Dr. Pushpa.
Thank you very much. Good morning. So the paper is exploration of timing of the deliberate self-poisoning presented to primary care institution in rural Sri Lanka. So we all know that our self-harm rates are very high. And though the suicide rate is coming down, all the researchers agree that attempted suicides or the deliberate self-harm rates are rising. And in rural agricultural Sri Lanka, around 1% of hospital admissions are due to self-poisoning. And around 10% of ICU admissions are due to self-poisoning. Anyway, the pre-hospital delay as well as in-hospital delays primarily associated with adverse outcomes. So our objective is to explore the timing and deliberate self-poisoning present into primary care institutions in Kurunegala district. So it was a cross-sectional study. We have conducted it over 3 years from 2011 to 2013 in all 46 hospitals in Kurunegala district. The details related to timing of deliberate self-poisoning event and admissions were extracted from the hospital records for that period. So basically we have found 11,125 DSP events, deliberate self-poisoning events during this period after removing the double counting due to transfers and readmissions. There were 26%, almost 1/4 of admissions came to 3 base hospitals, and about 60% came to 19 district hospitals, and rest for the other primary care hospitals. Teaching Hospital Kurunegala is the tertiary care center there, so it receives about 60% of the self-poisoning events in the district. So this is actually the age-sex distribution of self-poisoning. Anyway, I am not going to discuss because that is not the scope of this study. So let's move on to the incidence. So we have found that there were generally higher number of incidents all the months over the year, but we have found that in January, July and August, there were higher number of admissions among males, and June, July and August, there were higher number of admissions in females. This is basically associated with the agricultural work pattern and availability of pesticides in the households. And when it comes to the again about the we have found that significant decline in November. Again, it is associated with the agricultural work and availability of pesticides. So when it comes to the day of the week, we have found that there were a lot of males were attempted on Saturdays, and females both on Saturdays and Sundays. And towards the mid of the week, we have found again a decline. So when it comes to the timing, we have found that highest number of cases were seen in evening 4 to 8 p.m. period, both in males as well as females. And even after that, the second highest number found in 8 to midnight period. So about the timing of the admission, so we have found that again similar to the events. So highest number of admissions were found in 4 to 8 evening period as well as 8 to midnight night period. Time gap between the ingestion and the admission. The median time was almost 2 hours. And we have found that it was significantly shorter in males. So there's a limitation because our data set is a bit older. Now we have done the study about 9 to 10 years ago. But believe me, and we have enough literature, the pattern is not changing. Conclusion, the primary care institutions in rural agriculture Sri Lanka prepare to manage higher number of deliberate self-poisoning emergencies from 4 p.m. to 2 a.m. That means from evening to early morning or midnight period during the weekends throughout the year. Not only that, even all the other days. I recommend in-depth exploration on services availability during specifically in the weekends at night. Thank you.
Thank you, Dr. Pushpakumara. Thank you very much for sticking to time. We have your 2 minutes for discussion. The paper is now open for discussion. Any questions from the audience? Please do ask questions, because if you do, you also learn. Yeah, so till the audience thinks, but I have 2 questions for you.
Yes.
First is the deliberate self-poisoning. What was the poisons used?
Mainly pesticides, then the medicines, and biological poison is also there, like Kaneru and those things.
And the second one, the study, as you quite correctly noted, was done in 2013.
Yeah.
So based on that, now we have about 7 years.
Yeah.
Did your recommendations of this 2 to 4 p.m. to 2 a.m.
Yeah.
was it sort of implemented and circularized, and how was it made aware to the hospitals in the periphery?
Actually, sir, this was not published. I mean, this part was not published. Actually, it is my duty to communicate with the RDHS and the PDHS office in addition to the scientific publications.
Yeah, I think you should do that, because it might save at least one life. Yeah, so you also mentioned that the pattern has not changed, no?
Yes, sir. Pattern has not changed, because I mean later on we have done some of the survey-based, I mean small studies, because I mean to help our publications. So we have found still the pattern is same.
Okay. So you have any questions?
Yes. Yeah, your conclusion is about adolescents.
Yes, sir.
Yeah?
Yeah.
The age group that you have studied varies from 20 to 24.
No, actually, I mean we have included all the age groups, sir.
Okay.
But when we go through the numbers, actually, I mean higher numbers are coming with the adolescents. That's why I show you the age sex distribution, because a higher percentage are adolescents, less than 19 age group.
Less than.
Yeah, less than 19.
Okay. Now, in your abstract, it is not highlighted. Right?
Yes, sir.
And the other thing,
Yeah.
the study was confined to Kurunegala. am I
Kurunegala
right?
district, yes.
Yes. So your topic says scale to identify deliberate self-poisoning risk in rural Sri Lanka.
Yeah, yeah.
You can't project it to the whole of Sri Lanka, having studied only one district. Right?
So yeah. I mean, ideally it should be named as Kurunegala district.
Yeah.
So I prefer to use rural Sri Lanka, because I mean when you go through the pattern, so even in all the agricultural districts the pattern is same.
So that which you have not mentioned here.
Yeah.
And you have no data to say that.
Yeah,
So you can't
definitely. I mean,
arrive at
yeah,
this
within the paper
sort of
I can't
conclusion.
tell. Yes.
Yeah?
Yeah.
Yeah. Okay.
Okay. Thank you, sir.
Thank you very much, Dr. Pushpakumar, and we hope you bring this to the notice of your RD and PD very soon. Right, so the next paper is oral presentation number 3, and the study is titled A Study on Patient Satisfaction with Service Delivery at a Family Medical Clinic, and the paper is authored by Gobit R. and Rajiv G., and the paper will be presented by Gobit R. Over to you.
Good morning, everyone. The study on patient satisfaction with a service delivery at the family medical clinic, which is done in District General Hospital Negombo. Studying patient satisfaction is widely measured for the evaluation of the medical care and perception of care deliveries. It further identifies the need and expectation of the client in view to improve the service of the healthcare institution to achieve the better satisfaction level. The patient satisfaction typically refers as an individual satisfaction at a healthcare institution or setup, and an individual receive healthcare directly. You on at in 2020. This you all know the Family Medical Clinic, the setup in Sri Lanka. Almost all the secondary care center above the base hospital have the Family Medical Clinic, where the adult population come for the long and continuity care for the mainly for the non-communicable diseases and other diseases. That based from the concept, the family medicine principles are incorporated at the family medical clinic, where deliver the personal and family care in comprehensive manner. The curative and preventive care provisions are delivered with a continued long period. Medical and allied health services are coordinated at the venue. This is from the ministry website. So for the study, we have taken for some conceptual framework. There were the multiple frameworks. They are like a concept of service quality and customer service. From the Prasaramanan team in 1985 stated that service quality is viewed as a degree and direction of discrepancy between client's perception and expectation. Also, there's another model called a gap model. So here identify the gap between the patient and service provider. Also, another directed to the healthcare, there's another model called patient satisfaction survey model. This was Grant, Marshall, and Hay in 1894. This was taken here as the study material. I'll take it some more about this patient satisfaction model. They are taken as a PSQ 18. Actually, originally they are developed with the 49 arm of that questionnaire, but then they are divided into the 18. They are studying not only with the general satisfaction, with the subscale of satisfaction also they are studying with the technical quality of the healthcare provider, interpersonal skill, and communication between the patient and financial aspect, even though we are doing the free of healthcare at the point, but still there it has included, and time with health staff. So how the patients allocated with the staff and how they spend with them, and accessibility. And these are the factors influence the patient satisfaction. From that, there's a patient's point of view, even for the healthcare point of view, as well with the healthcare provider point of view, there's a factors are there, we will come in the discussion. For the methodology, this is a descriptive cross-sectional study. Study was conducted from the period of between 2021 August to October 2021 at the District General Hospital, Negombo, at the Family Medical Clinic. Study population was 800-200. From the inclusion who are followed more than 3 months there, and exclusion who are unable to communicate verbally. From the standard method, we have selected 429 patients through the systemic random sampling. And for the instrument, so we have developed a questionnaire based on the PSQ 18, and with the incorporate with this demography in subscale of satisfaction and perceived healthcare. And finally, this was getting the institutional and ethical review committee in the IHS. And finally, it was statistically analyzed. When they are making the questionnaire, we have taken the general type. What are the general satisfaction towards patient at family medical clinic? What are the factors that make patient satisfied at family medical clinic? What patients think about accessibility and convenience service? Are patients satisfied with the current setup and service provided at family medical clinic? Is there any financial strain at the access to the service there? So from that we have taken this survey questionnaire and validated. From the results, we can see here almost 87% of 2% are visiting monthly. Some are getting for the twice a month. And for the duration, almost 69.5, 70% are visiting there for the more than 1 year. And referrals almost come from the same institution, 92.3. And referrals are, the units are from the outpatient department, primary care units, and medical wards, also from other medical clinics. And from the patients who are taken, they are using the public transport in 62% of percentage. From the age-wise, from the below 40, around 80%. Here, female population are more in 68.8. For the education level, we are taken for the completion of the questionnaire from the most of the around 60% are from grade 6 to grade 11, and almost 73% of persons are living as an extended family setup. and almost more than 50% are having their monthly income of less than 10,000. So from the disease pattern, here non-communicable diseases are more in there, and from that the diabetic has 40.9 percentage, and next one the dyslipidemia 31.3, and hypertension 21, other respiratory diseases and all some percentage, and from that cumulative 73% are from the NCD in count on this. And receive services for the family medicine. We all know most of we think they come for the take the medicine. Yes, the consultation, all 95% of 5-1 are come for the consultation. From that, around 90% are getting medication there. Also, they are getting other services, counseling, health education, and medical referrals, allied health referrals, and preventive and coordinated care. For the data and the patient pattern satisfaction, here, even though the general satisfaction was come as 75.8, but the general, the overall one, the technical quality and interpersonal and other financial and spending time come as 69.3 with a mean of 52.59 with the standard even 6.9. So overall, the summary show the relatively high level of general satisfaction and overall satisfaction. And in addition, the interpersonal connection between patient and healthcare was significantly high, 97.5. This is a key during the service delivery. The convenience services and adequate spending time with the patients are once again positive. Here we have to note that satisfaction on the communication between the patients are around marginally around 50.5. And conclusion about the gender satisfaction was good, but still we have to achieve the overall, we need the communication and skill and more. Recommendation, communication skill training should be, we can arrange and incorporate with the staff who are trained in family medicine. These are my references. Thank you.
Thank you very much for that presentation. Yeah, so the paper is now open for discussion. Yes, sir.
Yes.
Nice paper, Gobit, but just want to ask, this family medicine clinic,
Yes.
are you open throughout the day? Are they, anybody can reach this 24 hours or is there a time span?
No, sir. This was in the every day, daily, the weekdays. Even Saturday also they are the half day, 8 to 12, then 2 to 4. I have mentioned the schedule appointments there. Actually, they have to schedule, but through I have mentioned also where they come from, then our patient department or other units and all. So schedule appointment for the long-term care.
So my question is, if these patients have any problem out of these working hours, what is the plan in the family medicine clinic for them to reach your...
Yeah, so normally the hospital setup like if they anything wanted, they have to go to the primary care units,
the
PCU,
OPD.
yeah, PCU, and they will get it set.
And do they, the PCU doctors would link up the next day with the family medicine clinic?
Yeah, they will,
the
because but they are mentioned and give the card, then they will follow up again there.
Okay, thanks.
Any more questions? Yes.
Yeah. Your title, Study on Patient Satisfaction with Service Delivery at a Family Medical Clinic. I think in Sri Lanka, we have the government sector and the private sector.
Yeah.
So that should be mentioned.
Yes.
Okay? That should be mentioned. And just a comment, a study on patient satisfaction. That is not necessarily a study on patient satisfaction. Just say satisfaction with service delivery at a government family medical clinic. If you are writing it to a journal, you must say Sri Lanka. So you need to cut down the number of words used in the title. That is very important. And it should really reflect where the study was done, right?
Yes.
That's one. And who filled the PSQ questionnaire, PSQ 18 questionnaire? Who filled
It's
that?
an interview questionnaire, sir.
Interviewed.
Yeah.
Okay. Is it available in Tamil and
Yes, all the
Sinhala?
language we have translated. And content
Was it
validated.
validated?
Yeah, content validated.
How did you do the validation?
Actually, sir, that we have through our doctor's team, we have validated, and after the patients also given, and there's some requirement, some direct wording has some wrong on the patient who are using. So with that, so content has validated.
Okay, yes. Now here in the abstract book it says patient satisfaction questionnaire was used. And you, of course in the presentation you said based on that you prepared one. That is important.
Yes, sir, that because main patient questionnaire was PSQ 18 was incorporated into that our questionnaire.
Yeah.
Because that is the main one from our conceptual model.
That should have been mentioned in
Yeah.
your abstract
Yeah,
book
okay.
also. Yeah?
Yes,
It's
sir.
that you have prepared the questionnaire.
Yes, sir.
That's important. And yeah, you say relatively good level of satisfaction.
Yeah.
That is bit ambiguous, you know, when you say relatively. Relative to what in relation to, right? And I mean, research finding should be really solid, right? Relative, one may have to contact you and Dr. Gobit, what is the definition you use for relative satisfaction? Okay, those ambiguous things should not be there in a research paper. And you say the subscale
Yeah.
of satisfaction, there was a significant association which should have been mentioned with the statistical test and the level of significance.
Yes,
Right?
we analyzed that only that with the interpersonal relation with the patient and healthcare
Yeah,
providers.
yeah. You could have said at this level of confidence level,
Yeah,
5% or whatever, right?
Yes, sir.
And the P should be indicated.
Yes, sir.
Right?
Okay, sir. I think
It,
I
it seems that you have calculated only the percentages. Right? Okay.
Thank you very much,
Okay,
Dr.
sir.
Jayati, sir. Can we thank Dr. Gobitar for his presentation? Now may I invite the next paper, free paper, which is Exploration of Clinico-Epidemiological Predictors to Reduce SAD Person Scale to Identify Deliberate Self-Poisoning Risks in Rural Sri Lanka. The paper is authored by Pushpakumara PhD, Adhikari AMP, Tennakoon SUB, Abesingha Ranil, and Dawson Andrew. And I think the paper will be presented by Dr. Pushpakumar. Over to you, Dr. Pushpakumar.
Yeah, thank you, sir. So this paper is exploration of clinical epidemiological predictors to redefine the SAD person scales to identify the deliberate self-poisoning in rural agricultural Sri Lanka. So we all know that self-harm is a global problem which has, accounts to nearly 1 million deaths annually. And Sri Lankan suicide rate also among the one of the highest rates in the world. And as we discussed earlier, though the suicide rate is coming down, number of self-harms are increasing. So the majority of deliberate self-poisoning in rural Sri Lanka occurs among adolescents and young adults who do not have major psychiatric conditions. Basically, it's a kind of a conveying their stress. The SAD person scale is one of the best known, most widely used scales to assess suicidal risk in emergency and primary care settings, which has 10 points. But some researchers has questioned the use of SAD person scale in primary care settings due to higher false negative rates and some practical implications. So let's move on to the methods. So this study has two components. That is cross-sectional study, which has done over 3 years in 46 hospitals in Kurunegala district, and the case control component, which has been done in Teaching Hospital Kurunegala. with the sample of 438 subjects selected randomly. So the cross-sectional component, we have collected demographic details from the hospital records. For the case control component, we have collected information through an interview administered questionnaire and other details about the suicide attempt through the Beck's suicide intention scale validated version, and psychiatric conditions were assessed using a structured clinical interview for DSM disorders 1 and 2, fourth version. We have collected 11,125 DSP events, deliberate self-poisoning events in the district, and there were 438 cases in Teaching Hospital Kurunegala randomly selected. So you can see, anyway, from this point onwards, I will present in your right hand side the points of the sad person scale and left hand side points of the sad person scale and our findings in the right hand side. So sex, it says in a sad person scale male sex is higher risk, but we found that it's almost male to female ratio is 1.1. So in young age groups more females, the old age groups more males. So the validity of that statement is questionable. So age, it says less than 19 and more than 45, but we have found highest incidence rates in females less than 19, but males it's less than 24, 20 to 24 age group. So again it's questionable. So when it comes to the depression and hopelessness, we found that there's a significant association with depressive disorder and self-poisoning. But the age, when we separate the age groups, we found that the significant association found only among the persons who are older than 30 years. And the lifetime history of previous self-harm reported by about 10% of people, and we have found 1/4 of subjects had psychiatric disorders. Among them, 75% of people were newly diagnosed. There were no previous history. So, but we found that borderline personality disorder is very prevalent as well as there is significant association. So I suggest this P instead of that P. Alcohol use, again we found that there is a significant association with alcohol abuse, but again the age analysis shows that it's significantly associated with people who are older than 30 years, especially males. When it comes to the rational thinking loss, we have discussed only 1/4 of people had psychiatric disorders, but when it comes to the psychotic illnesses or psychotic symptoms, only 1.1% had psychotic symptoms or psychotic illness. So, but nearly 90% of people reported that their proximal trigger is relationship issues. So I suggest this R instead of that R. So and majority of cases were single. So majority are young adults and adolescents. So what's the clinical validity of that? So but we found that having immediate family member who had history of self-harm carried 3.2-fold excess risk. So I suggest this S instead of that S. So only 1.2% had extensive preparation, and less than 1% had definite plans. And whole attempt, the time gap between the initial suicide ideation and the attempt is about 15 minutes. So there's no much planning. So, but we found that leaving the school before O-level carried 5 times excess risk. So I suggest this O out of that O, instead of that O. And no social support for that age group is not really valid for that our context. That is actually for Western countries, older populations. But we found that neglecting and emotional abuse in the childhood has a real association with deliberate self-poisoning. So I suggest this N instead of that N. Stated future intent is very important, and again there are some limitations. So my conclusion is interpretation of sad person scales to identify self-poisoning in rural Sri Lanka, where the adolescent deliberate self-poisoning incidence is very high, should be done with caution. And in-depth exploration suggested to determine the sensitivity and specificity of this scale. Thank you.
Thank you very much, Dr. Pushpakumar, for that presentation on the sad person's scale. So how do you, again, the question is, this is again an old set of data within 2011 and 2013, but you clarified in your previous that the same pattern you saw in the
In addition to that, sir, I mean, when we go through the economical status of those districts and other risk factors, they were not changed basically. And poisoning patterns also little bit different now, because I mean they have changed it pesticides to more or less medicinal ones, but still all the other risk factors are same, because I mean recently we have published a paper as well saying that the same thing. Okay. So I think the findings are still valid.
Okay. Any questions from the audience? Yes, sir.
Just a question, have you looked at the GP role in handling this kind of patients and
yes, actually, we have collected some of the data, and we have found that fair amount of people have visited GPs and express not really the suicide intention, but express their their problems with the GPs. But probably they have not really identified the suicidal risk at there.
Who did the interviews?
So
how many people?
Yeah, I mean, for the cross-sectional studies, actually we have got details from the health records.
Okay.
Case control study, psychiatric assessment was done by a specialist psychiatrist using that structured clinical interview. Other data were collected by our research assistants and by myself.
So there were 438 cases.
Yes.
Controls, how many?
Again, sir, age and sex matched.
Okay, now the number is
438.
Okay, it's not mentioned, right?
Yeah.
It's important.
Because to be honest, sir, I mean, within 250 words, I had to select which to include and which to exclude.
Yeah. Now,
I accept, I mean, this should be included.
Okay, certain things now, the exploration of clinical epidemiology, things like exploration of, those things are not necessary, right? And why do you say redefining is to the question is necessary? It was not highlighted in your presentation or the abstract book.
Yeah, in the abstract, I believe that it is not highlighted very well. Because the thing is, I mean, we have just researched the factors in sad person scale. That's all, but we didn't check really the sensitivity and specificity of those factors with regard to the assessment of suicidal risk.
Without checking the sensitivity or specificity, how can you say redefining is necessary?
Because the thing is, when we go through even the age group, so it's different. So, and set of other factors also, we have found that they were not really statistically significant, but there are some other more important factors which are associated with deliberate self-poisoning are there.
Can we move on, sir?
Okay.
Thank you very much.
Thank you, sir.
Can we extend our appreciation to Dr. Pushpa? The next paper will be the oral presentation number 5, is prevalence of polypharmacy and associated factors among elderly attending to the accident and emergency department, District General Hospital, Nagoda, Kalutara. Paper is authored by Madhava Sanjeeva Dangampola Ranatunga RAN and Anekar PN, and the paper will be presented by Dr. Dang. Over to you, Doctor.
Okay, thank you. Good morning. And I would like to take this opportunity to thank CGPSL for giving me this opportunity to present our study. So my study was on prevalence of polypharmacy and associated factors among elders attending to accident and emergency department in General Hospital, Nagoda, Kalutara. And elderly is defined as the time after 60 years of age of a person. And we all know the proportion of elderly is on rising in local and global contexts because of changing from higher birth and death rate to lower birth and death rate over the past few decades. People with aging have more risk of developing chronic illnesses as well as disease-related and treatment-related complications due to frailty. Since most of the elderly are on allopathic medications, they are more vulnerable, more prone to polypharmacy. Polypharmacy is most commonly described as use of 5 or more medications daily by an individual, and it is usually seen in elderly. With the polypharmacy, the elderly are in risk of increased treatment burden, increased adverse drug-related events, and increased hospitalizations, and increase in drug-related cost, and increased drug interactions, and reduced compliance. But with the goal-directed or guideline-directed medical therapy, they have increased quality of life, reduced number of hospitalizations, and increased survival. So the objectives for our study was to determine the prevalence of polypharmacy among elders and to compare the factors associated with polypharmacy and non-polypharmacy among elders, and to describe common drug classes prescribed in polypharmacy among elders, and to compare the clinical presentation, signs, diagnosis, and outcome in polypharmacy versus non-polypharmacy among elders. So this shows the conceptual framework for our study. So we try to assess the relationship between polypharmacy, sex, age, income, chronic illness, education level, and occupation. So our study was a descriptive cross-sectional study which was conducted in a single center, accident and emergency department, General Hospital, Nagoda, Kalutara, over from March 2022 to April 2022. And the study population was patients above 60 years admitted to accident and emergency department, and we used consecutive sampling method. And the patients with cognitive impairment, transplanted patients, patients without bystanders, and information on drug treatment were excluded from the study. And we gathered data by using a structured interviewer-administered questionnaire and also by using clinic books. Ethical clearance was taken from Ethical Review Committee, Faculty of Medicine, University of Colombo, and we also taken informed written consent from the patients, participants before gathering data. And data was analyzed using SPSS. And out of 275 patients in our study population, most of them were middle old, 43%, aged from 70 to 79 years. And out of those 275, 53% of the patients were male. And most of our study population educated above grade 5. And the prevalence of polypharmacy for our study was 47.6%. And the most commonly used drugs in this study population was atorvastatin, aspirin, losartan, metformin, gliclazide, and clopidogrel, which were used for non-communicable diseases most of the time. And when considering the relationship between risk factors and polypharmacy, the age, gender difference or the age variability, there was no significant association with the polypharmacy. And when they were prescribed by more than one prescriber, there was 2 times higher risk of getting polypharmacy, and also it increases the risk of non-compliance by 2-fold. And this number was statistically significant in our study. And we couldn't find any statistically significant association between education level, occupation or the income level for polypharmacy, and there was no significant difference in disposition or the outcome of the patients associated with polypharmacy group. And with these findings, I conclude that consulting multiple prescribers is the main risk factor for polypharmacy, and it leads to poor compliance as well. So I recommend that our prescribers need to pay more attention on minimizing polypharmacy, and also we need to educate our elders regarding polypharmacy and its effects. So our study was limited by the limited sample size, and also it was a single center study carried out in a government sector hospital, so there's problems with generalizability. So thank you for listening.
Thank you very much, Dr. Dagampal. Can I have your slide on the drugs you showed? Yeah, that's one. Right. So who prescribes these? Like if you go through the, it looks like a cardiologist, a physician, yeah, basically a cardiologist and a physician, no?
I found that patients are going to government clinics as well as the private sector, the specialists as well.
That's very good. So the private sector, if you could have told us a little where they went, could have been better. Why I'm asking that is you have a very valid point that multiple prescribers, the point I'm trying to make is how do you reduce people to going to multiple prescribers in Sri Lanka? So don't you think they should have quote unquote a primary care physician who looks at all this?
Yeah, I think we need to establish that thing, but I don't think we can do it through the patients. Patients used to go, they are going doctor shopping. So I think that as prescribers, we should initiate that thing, and we should establish it in our, as a system.
Educate the patient.
Yes, educate. Yes.
Can I just push you a bit and ask you how exactly again? I'm just proposing, what if you have a functional referral system? Say, for example, to like in other countries where they have, example, if you want to prescribe atorvastatin or whatever, from the, you get what I'm trying to say, no?
Yeah.
Why don't you put that
if you want to go to a specialist, you need a proper referral system. Here, like a patient can decide, I should go to a neurologist, I should go to even neurosurgeon, they decide and go.
So also, even within your government hospital system, there are, you said, multiple prescribers. So different clinics sometimes prescribe the same thing and it overlaps. So we have seen it in our GPs clinics all the time.
I also noted that sometimes our endocrine clinics prescribe cardiology clinic drugs. Patients feel it is easy because they can get all the medication by a single visit, so they don't go to the other clinic most of the time. That's what happens.
Polypharmacy never happens. You know, that either prescription itself goes to the preferred pharmacy, so pharmacist will never, substitute it again and again. So rather than, trying to curtail specialist or freedom of patients going to their choice of doctor, I think I'm talking about the point that you were trying to push. We should have some sort of some form of regulation at the pharmacy level, or where patient can buy the products. At that point, we can, I think, regulate more.
Yeah, okay, I take your point. Thank you very much.
Can I ask a
yes,
question? Did you all calculate the sample size for this?
Yes, it was 375, but I couldn't achieve that sample size because I had to carry out this during the COVID era, and also I conducted this in
okay,
department.
now without using correct sample size, the findings of a descriptive cross-sectional study, right, not valid.
Yeah,
Right?
that's why I mentioned it as my limitation.
How can you write a paper without having a sample size, correct sample size? You have calculated it, which came to about 300 dot, and you have done only 275. That's one point, right? These elderly, they suffer from lots of comorbidities. So can we always avoid polypharmacy?
No, there's two things called, one thing is appropriate polypharmacy, other one is inappropriate polypharmacy.
Yeah.
So I didn't go into that details to assess whether this is
So,
appropriate or not.
this you would have probably investigated the appropriate polypharmacy, right? Yeah, because you did not look into that factor, right? I mean, especially elderly, right? Now see, look at that one: atorvastatin, aspirin, losartan, metformin, glycoside, 1, 2, 3, 4, 5. Clopidogrel, I don't know. That again, a patient who had a bypass surgery recently would be on aspirin and clopidogrel for some time.
Yeah,
So
sometimes.
this- for some time.
Yeah,
That is the thing.
that is only for 9 months, but still I have seen so many
No, no,
people
no, no.
are
You can't say.
prescribed long,
You can't
but I
say.
don't.
You can't say I have seen. This
Yeah,
is
but-
research.
Yeah, that's why I didn't mention like it in my paper or the presentation. I may be biased, so
You are, honestly. Yeah, because this is scientific paper, right? Okay, thank you.
thank you.
Thank you very much, Dr. Dangulpudi. I think you have raised some very important points for us. Can we show our appreciation to the... moving on to the next paper, which is oral presentation number 6, a series of child abuse cases which are admitted to a tertiary care hospital which could have been easily missed. The paper is authored by Fernando KMD, Dimal DA, and Aloysius R. And the paper will be presented by Fernando KMD. Over to you, Dr. Fernando.
Good morning. I am Dr. Dinusha Fernando. So today I'm going to speak about child abuse. Just imagine, for the last 2 years' duration, how many innocent children, how many budding flowers were damaged and destroyed prematurely, without seeing the light of the dawn. No wonder you would have thought child abuse should end. But the question is how? You must be eagerly waiting as a medical officer, how can we prevent child abuse? I'm going to take you all to the current state of child abuse in Sri Lanka. It is said 1 out of 10 children suffers from some kind of a sexual abuse, and 90% of the abusers, perpetrators, are a well-known person, a person whom they love and trust. So imagine a child divulging an unpleasant story to a third party, and the unpleasant event has occurred by the caregiver. So the child abuse reporting rate is underrated in Sri Lanka. Not only that, when it comes to cultural aspect, especially when there's a child abuse of a female person, the guardians bring the child as soon as possible to seek medical attention with the concerns of virginity and pregnancy. But when it comes to males, it's not the same way. So, the child abuse cases in Sri Lanka are underreported. I just want to say that we are seeing only the tip of the iceberg. So today, I'm going to present a couple of child abuse cases which was presented to a tertiary care hospital and was managed in order to make you all aware about the common presenting complaints of child abuse and how we can prevent them. So this is a 7-year-old boy brutally sexually abused and admitted to a tertiary care hospital in 2020. So this child was under care of intensive care unit for a couple of days and we couldn't save the child. So when evaluating the story, the child's parents were separated and the child was living with one of the relations of his. And then this relation has frequently abused this child, and he had taken the child to a couple of general practitioners as well as OPD, outdoor patients department in nearby hospital for painful defecation and constipation on several occasions. But if the doctor, in the first contact doctor, would have been suspicious more, we could have saved this child. And there's another case. 14-year-old girl with Down syndrome, a mentally retarded girl, was sexually abused by a gang. And on evaluation of this case, this 14-year-old girl, parents were living abroad, both of them. And she had been looked after by her uncle and aunt. So this uncle, including 5 people, has recurrently sexually abused her. And then he had taken her to a family physician with the complaint of abdominal pain, urinary symptoms with purulent discharge. So luckily, this family physician was so suspicious about the incident, and then he had underwent investigations, and on investigations he found that this girl was positive for sexually transmitted infection. So luckily, we could arrange a case conference, institutional case conference at the tertiary care hospital, and now the child is in safe hands. So let me highlight to you the common symptoms and signs of sexual abuse of children. So usually, the presentation is delayed. Recently, we got a child with a frenulum tear. It was a child abuse, sexual abuse case, and this incident has occurred 2 days back. And usually, these are all fabricated stories when the presenting, so the history changing from time to time. And not only that, as I mentioned earlier, the clinical features, when there's a purulent vaginal discharges, vaginal bleeding not correlating to menstruation, painful defecation with or without bleeding, and unexplained somatic symptoms, headache and abdominal symptoms could be there. And also, there can be behavioral changes. Children can be having sexual hyperactive behaviors, avoid places and special people, deterioration in the school performance, and social problems, parents separated, and parents are very busy or parents are abroad. And physical abuse is another entity of child abuse. Deliberate attempt to hurt the child, and modes of physical abuse include hitting, biting, and burning. So this child was 9 months, just 9 months. We admitted to the tertiary care hospital saying that this child underwent a burn injury in hand following spillage of hot water. So what happened was we discharged the child, and after 1 month's time, coming with multiple fractures. So usually, there are types of burn injuries in sexual abuse, where the perpetrator forcefully put the child's hand in hot water. So you can get glove and stocking type burns. Not only that, when the child is forcefully immersed in a tub, you get the sparing of buttocks and knees and getting these typical burns. And these are the x-rays of the child coming with multiple rib fractures, humerus fractures, and skull fractures after 1 month duration. Actually, what has happened is the mother's extramarital partner has physically abused the child. So we could have prevented this if we could have evaluated the case in the previous visit. And not only that, I need to highlight the Munchausen by proxy, where the mothers used children so that they can admit the children to get rid of from their various problems. Now, this mother coming with 3-year-old child, saying the child is having recurrent hematuria, and admitting and staying in the hospital for 4 to 5 days duration. But however, we found that she has mixed the menstrual blood with urine, so that she had family disputes and she wanted to get away from the family, and she used this. So not only that, parents heat up thermometers to look the child's ill, and they infect IV lines to make the child ill, and they give drug to induce child's vomiting. So I just want to mention that Sri Lanka College of Pediatricians with the National Child Protection Authority has made a guideline in 2017 to manage these kind of children. And we have a place called Lama Piasa, which is at Colombo North Teaching Hospital, where we can keep the children till the legal aspects being performed. So this is a number you can call, even the child line in Sri Lanka, to protect these kids. So take home message: if you see a child with unusual presentation, be more suspicious and investigate further. And I would like to thank the Sri Lanka College of Pediatricians for giving me the opportunity to present today, and Sri Lanka National Child Protection Authority and Sri Lanka College of Pediatricians for the material and student materials to present today. Thank you.
Thank you, Dr. Fernando, for that very informative study. It is a very nice series of cases you have seen. So thank you very much for taking the trouble to record it and presenting it to this particular audience who will actually statistically see 50% of all the cases you are going to see. So thank you very much. And I hope the take-home message is taken by all of us, and when we see patients, we will use it. Dr. Jayatis, any question?
Yes. It's a very good presentation.
Thank
very
you,
good
sir.
presentation, very informative, timely and appropriate. Still, in Sri Lanka, I think the child abuse is not detected. It's still only the iceberg is detected. It's iceberg phenomenon. And can we say it's a research or a study? What is the study design, we call it? Anyone in the audience? Because let it be a bit of a learning session also.
Yeah, like Dr. Jayatis is about to say, this particular thing was deliberately chosen.
Not really. No.
Case
But
studies, yeah.
This is, the design is under descriptive studies. You'll know that studies could be divided into descriptive and analytic. This is descriptive. Under that, one is cross-sectional. Like that, there are two others. Case study. You just report some case which is not seen very often, or a new case, or a new presentation of a case. And this is what is called case series. Study design is descriptive case series. That's very good.
Thank you very much, sir.
Thank you very much. And can we show our deep appreciation for this paper? I think it brought out a lot of... Thank you very much, Dr. Fernando. Right, moving on. So please do remember, if you have very important cases you have seen, for the first time you might be seeing certain cases, so there may be not any, like Dr. Jayatis says, any analytics involved, but certainly it is of scientific value to bring it to the notice of the scientific community. So with that, we are moving on to oral presentation number 7, which is the launch of a HIV self-testing in Sri Lanka. And the paper is authored by P.S. De Silva and Satya Herath, and paper will be presented by Dr. De Silva. Over to you, Dr. De Silva.
Thank you, sir. Good morning, ladies and gentlemen. I'm Dr. Sandaru De Silva. My presentation today is about the launch of HIV self-testing in Sri Lanka. HIV self-testing has been recommended by WHO as an innovative strategy to reach the unreached and for people who do not attend the services. The evidence shows that HIV self-testing is a safe and accurate testing method. It is highly acceptable. It increases the excess, uptake, and frequency of HIV testing. Testing will be increased in those at high risk and who may not test otherwise. As you all know, Sri Lanka is working towards the target of ending AIDS by 2030. But we are facing a lot of challenges in the journey towards elimination. We are far behind the target set for testing services. HIV self-testing was introduced to Sri Lanka in year 2020 with the aim of reaching testing services to the unreached population. Moreover, with the current global COVID pandemic, HIV testing was challenged. Hence, introducing HIV self-testing was timely in Sri Lanka. The National STD AIDS Control Program procured 10,000 oral kits, and the distribution of test kits started in December 2020. Kits were distributed through many entry points, the network of community-based organizations, government STD clinics, and also through the web-based portal knowforsure.lk. Hotline was also introduced to order a free HIV self-kit whenever a client is in need. So this is the hotline that was initiated, note 71-637-9192. User demographic information was collected upon distribution of a kit to a client. The self-kit usage was advertised through social media posts. The reporting of test results was encouraged for the clients, but was not mandatory. User instructions was given through leaflet with the test kit and the hotline services. A client who ordered a test kit was provided with a leaflet with Sinhala and Tamil translation, and this self-test kit was an oral fluid test. And maximum of 2 test kits could be ordered, and there was a feedback form in all 3 languages, and we provided a self-addressed envelope to feedback us. And also, if the test kit was delivered to home, it was wrapped in white and brown paper. So as of April 2022, 80% of the procured test kits were distributed. From the distributed test kits, we have got a 50% test results, and 17 new HIV cases was identified through this testing. The positive cases were mainly reported through the community-based organizations, that was 14 in number, through hotline 2 in number, and through STD clinics 1. So this HIV self-testing is a screening test, and there is a window period of 90 days. If the test kit is if the test is non-reactive and the patient has had a high exposure within 90 days, we will have to test the person again after 90 days of exposure. If the test is non-reactive, we can give the normal HIV testing package that we give with promotion of condoms. And if it is reactive, we have to refer the patient to the STD clinic for further testing. So there were 2 models that was introduced in introducing HIV self-testing to Sri Lanka. One was through community-based model, that is through the hotline and community-based organizations. And also the facility-based model was also used because of this COVID quarantine healthcare settings. So in conclusion, HIV self-test kits are a very efficient way of testing the unreached population who has not been tested for HIV, and additional 10,000 kits have been secured, and additional models of distribution, including pharmacies and general practitioners, are being explored. More in-depth analysis is underway in order to inform national scale-up. It is important that general practitioners are aware about the HIV self-testing services. Thank you.
Thank you very much for that presentation, Dr. De Silva. May I quickly ask you, how does a GP individually or through a clinic procure these kits?
Through the hotline, sir. You can call the hotline, and there is a consultant vendorologist who is answering the phone, and the necessary posting and stuff will be done
So
by
it will
him.
be sent to the GP, right? Anywhere in Sri Lanka,
Yes, anybody can order. Anyone can order.
including the public, is it?
Yes, including the
So it
public.
doesn't need to be a GP or anybody?
Doesn't need, but if the GP knows these services, we can promote the
Sure.
services.
Thank you very much for bringing that to our
Just a
notice.
question. Yeah. What is the objective of this study?
Sir, the testing rates were very low in Sri Lanka.
Yeah.
So we wanted to increase the HIV testing.
I'm sorry, I didn't see. Was it mentioned in your presentation?
Yes,
Not
sir.
in the abstract. Objective is not there.
Okay, sir.
Right? And the title, Launch of HIV Self-Testing Sri Lanka, it looks like a kind of a report. But if you said efficiency of detecting HIV by this method, it becomes a study.
Yes.
Right?
Yeah.
Yeah. This is like a report, right? And conclusion number 2, an additional 10,000 kits have been secured and additional models of distribution. How do you conclude that? You are just reporting a fact. Am I right?
Yes, sir.
Yeah. It's
Yeah.
not a conclusion.
Yeah.
Right?
That conclusion came from the study that we have successfully completed the testing services with a very high caseload detection. So we have procured the for the next scale up.
Okay. Yeah. Okay. Right.
Thank you.
That is the outcome.
Yes, sir.
Outcome.
Yes.
Dr. Preeti.
How nice if you could have incorporated GPs also into your study, number one. Number two, you said some organizations reported 14%.
Yes, sir.
And your SCD program reported only 1%.
Yes, sir.
So that's very disproportionate.
This community-based organizations are for the key populations, sir. So they
So
have
what were
for female sex workers, MSM, men sex men. They have organizations for those specific groups. So through them, the reporting is very high, sir. Rather than they reporting the government clinic, they prefer
Through them.
getting tested. So the overall idea of this HIV self-testing is to get the unreached population that is not coming to the STD clinics to get tested, sir.
So there are organizations like these homosexuals and lesbian groups. Have you reached them, and do they report back to you with this kind of testing kit?
The National STD AIDS Control Program have links with these community-based organizations. To name them, MSM is promoted by
Yeah.
Heart to Heart. Those organizations
Or these gay rights organizations.
Yes, sir.
Yeah.
Yes.
Right, good. So anyway, I hope you'll incorporate the GPs into this.
Yes, sir.
in
They are
the future.
planning. Yes, they are planning for the scale-up.
Thank you very much.
Thank you, sir.
Can we express our appreciation to Dr. The next study is the oral presentation number 8, self-perceived competency in intravenous cannulation among prospective medical interns in Sri Lanka in 2021. The paper is authored by Padiniya PSMAB, Nadishana BMVG, Veerasinghe K, De Silva AP, Vijayaratna NDK, Vijayaratna WHTP, and Pereira HMCNM. Paper will be presented by Nadishana BMVG. Right, so these are the 3 papers which are not there. Yeah, because I was told that there are 3 papers which are not here, so probably them. So can we just hold on to that and move on to the next one? Evaluation of knowledge, attitudes, and common practices among accident and emergency doctors for difficult intravenous access and use of ultrasound in selected tertiary care hospitals in Sri Lanka by Darshani AGT. Dr. Dinashani is inviting all of you for tea if you have not had, because we will be proceeding at 11 o'clock with the next program immediately. So if any members of the audience who have not had tea and who wish to have tea, please do so. I think they're closing at 11. Over to you, Dr. Darshan.
Good morning all. Let me present my research study on evaluation of knowledge, attitude and common practices among accident and emergency doctors for difficult intravenous access and use of ultrasound scan in selected tertiary care hospital in Sri Lanka. I have to rush through the slides because my presentation is a little bit longer one. Okay. So this is a layout. I will go each of topics. So intravenous cannula is necessary for 90% of the patients coming to the emergency department, and there is a chance of first attempt failure in 34% in general population. It can go up to 93% in some patients like obese patient and drug users and patient coming with shock. So this will lead to repeated attempts by multiple practitioners. Ultimately, they required complicated procedures like CV line insertion or intraosseous access or venous cut down. This will lead into anxiety to the patient and discomfort, and ultimately delaying the diagnosis and treatment. So here the ultrasound scan comes. Ultrasound has many purposes in our emergency department. When one of the standard care worldwide recognized one is used for the difficult cannulation. It will increase the success rate and fewer skin punctures and complications. But studies regarding the difficult intravenous access and use of ultrasound is in Sri Lanka. So objective of my research was to describe the demographic data, knowledge, attitude and common practices on difficult intravenous access and use of ultrasound among A&E doctors in tertiary care hospital, and describe the accessibility to alternative method, and describe favorable factors and barriers for using ultrasound scan for difficult intravenous access. So I did a descriptive cross-sectional study which was carried out in 6 main tertiary care hospitals in Sri Lanka, which included National Hospital of Colombo and Kandy and Teaching Hospital Ratnapura, Karapitiya, Colombo North and Anuradhapura. All the medical officers and the postgraduate trainees who have worked during the month of February to April 2022 was included, and ethical clearances granted from Medical Faculty of Colombo. And it was done via pre-tested self-administrated questionnaire, and these 5 areas were covered, assessed to cover my objectives, and data was analyzed through SPSS. So come to the core of my research. There were 158 responders, and 55% of them were male. And total of 158, there were in doctors, there were 2 categories, PG trainees and non-PG trainees. Those are the permanent staff who worked in the emergency department, consist of 46%. And mean average of the PG trainees was 35 years, and medical officers were 41 years, and mean experience was 8 years for the PG trainee and 12 years for the medical officers. And 42% of the doctors who work in the emergency department involved in putting cannula within 1 week duration, and 5% of them were not involved in cannulation nearly for 1 year. In this slide, I mainly concentrate on if they got a patient with difficult cannulation and critical patient, what was the first method they're going for. 31% choose ultrasound as the first method, and 21% use intraosseous access, 70% central venous access, and 11% venous cut down. And availability of the equipment, 28% of the department had intraosseous gun, and 32% of doctors have used it. And all the departments I studied had ultrasound scan, and 79% of the doctors use ultrasound scan at some stage of their career. From that 79%, only 10% use ultrasound very frequently. And I analyzed what are the influencing factors to use ultrasound scan. It was multiple choice question, and most doctors are happy with learning from the colleagues who had the experience and also participate into workshop. self-learning online, and previous successful attempts were encouraging factors. And barrier for the using ultrasound canvas, they didn't had proper learning or learn, but they're not confident, or they're scared to be failed in front of others, or they believe it is beyond their scope and satisfied with their current practice. And I asked my doctors to rate their confidence to put in central and peripheral cannula, rating them from 0 to 100. And there was statistically significant difference among PG trainees for inserting a cannula for peripheral and central cannula. And these are some questions to check their knowledge. I'm not going through everything, but overall, there is a satisfactory knowledge among both groups, and except for one question. Question number 4, applying a tourniquet is not useful in ultrasound scan. The answer was false. There was a statistical significance in medical officers and PG trainees. Other than that, knowledge was satisfactory. So the attitudes. 87% of doctors were happy to willing to participate for a training program for managing difficult intravenous access and hand-on session on ultrasound scan. So the conclusion of my presentation, knowledge, attitude, and use of ultrasound in cannulation among emergency doctors was satisfactory, and there is a gap in structured training program. All the teaching hospitals had ultrasound scan, and 79% of the doctors use it for cannulation at some stage of their career, but only 10% use it for very frequently, and only 31% consider it for ultrasound guided cannulation when they get a bad pressure. And there is a statistically significant difference in confidence among PG trainees for peripheral and the central line insertion. Observing and learning from the colleague was main enabler to use ultrasound, and lack of interest, lack of confidence, and lack of knowledge were main barrier to use ultrasound scan. And interestingly, 88% of the doctors were willing to involve with training program on ultrasound scan for difficult intravenous access. So these are my recommendations. Organize a regular and sustained training program for all the medical staff for difficult intravenous access and use of ultrasound scan. And staff should be encouraged to use the ultrasound scan for uncomplicated patients rather than the complicated patient. Then you can improve the self-confidence and get the patient feedback. That is very important. So these are some of my references. Thank you for listening.
Thank you very much, Dr. Darshini. Again, a very useful piece of information. I'm sorry, I had to do something else with regard to your presentation. Did you show us a photograph of the device which is used to do this? I'm sorry, I missed that.
Yeah, sure.
No, I'm asking the photograph of the ultrasound machine.
Oh,
So is it portable? Is it now some of us?
it is a portable.
Right,
Yeah.
exactly. So I have seen it at NHSL and so on. But this is an audience of GPs. So I think it would have been useful if you had shown it so that they could have incorporated in their practices, because more of cannulation is shifting from our A&E departments to the community. So again, we chose your paper because we wanted to give a message. So thank you very much for sharing. So please Google up and see the device. It's not very big. It gets smaller as time goes on. Yes,
Yeah.
sir.
Just by the same question, is it cost effective for GPs to use in their clinics, number one? And next question was, you said some people are reluctant to even learn about it. Why is that? What do you think?
I think that mainly it is personal view.
They don't want to get involved.
Yeah. They're happy with their current practices and not.
Yeah, so if we are to organize a workshop for GPs, how do we do it?
Actually, already there are currently going on sessions by the
What,
emergency
madam, you don't
department.
realize is there's this all for your state sector, no?
Yeah.
We are
So
talking,
we
yeah.
can collaborate with the emergency physician college and arrange some.
Right. So perhaps our college will contact you. And thank you very much. Dr. Jayathi?
Yeah, I want to say something. The title
Yes.
is too long.
Yes,
Is it
sir.
possible to, amend it? evaluation of knowledge, attitudes, and common practices among accident and emergency doctors for difficulty. It's too long. You studied the use of ultrasound in selected tertiary care hospital in Sri Lanka. That is in this. Again, it's out of fashion. Evaluation of knowledge, attitudes, and common practices. It was very popular about 20 or 30 years ago. You call them CAP studies, right? But it's a good study. And anyway, descriptive cross-sectional study, to say, I don't think that you have calculated the sample size.
No, sir.
To study with.
Yeah.
That is a must, because it affects the validity of your findings. Your sample is 158. Not bad, but this sort of thing, you can't say descriptive cross-sectional study. You can say, if you can't find enough cases, you can say it's an explorative study.
Okay, sir.
Right?
Okay, sir.
Which was not done before. So somebody should give a start. You call them explorative studies.
Okay, sir. Thank you, sir.
Thank you very much. Thank you, Dr. Jayati sir, for pointing out in each study the technicalities, and I hope the audience of young researchers will pick up that and in their future study designs. Moving on, may I now invite the oral presentation number 10, self-perceived competencies of nasogastric intubation. Ayodhya. Right. Self-perceived competencies in nasogastric intubation among prospective medical interns of Sri Lanka from 2019 to 2021. Padeniya PSMB, Vijayaratna NDSK, Veerasinghe K, Vijayaratna WHTP, Nadishana BMVG, and Pereira HMCNM. The paper will be presented by Vijayaratna NDSK. Over to you, Dr. Vijayaratna.
Thank you, sir. First of all, I would like to thank College of General Practitioners for giving this opportunity to present our study. The nasogastric tube insertion is an essential clinical skill expected to be competent from intern medical officers since the first day of their internship. Competence to perform the skill without supervision of seniors is expected for many clinical skills, including nasogastric tube insertion also. Prospective medical officers are the medical graduates, our study population, awaiting for commencement of the internship. Internship, though it is described as a training period by means, in developing countries rather than in developed countries, they are expected to be the first contact doctors for patients and also to work as the first on-call doctors. So the interns hold a very considerable amount of responsibility on patient management and also emergency care management within the ward while working as the ambassador of the ward. So the self-confidence on patient management and also on performing essential clinical skills of each and every intern medical officer, while each and every medical officer is important to assure the quality of patient care since it is affected the whole healthcare system in Sri Lanka. So we did this study with the main objective to describe the self-perceived level of competency in nasogastric tube insertion among prospective medical interns in Sri Lanka from 2019 to 2021. We created our specific objectives on to assess the level of competence in performing essential clinical procedures. Here I present the nasogastric tube insertion, to explore the need for and identify the contents of a preparatory program for medical internship, and to identify the instructional strategies and methods for the preparatory program for medical internship. We did a descriptive cross-sectional study with participation of 1,731 prospective medical interns within last 3 years, 2019 to 2021. A pre-tested self-administered questionnaire was used to collect this data, and we used a scale with 4 ranges: performing clinical skill competently without supervision, performing clinical skill with supervision, not able to perform skill but has observed the skill, and not able to perform the skill but has not observed the skill. I think we did this data collection since last 7 years actually. I think the summary data chart of our study will be clear to you, and we are if you consider the last 3 years, there's a significant changes in this data. While considering the results, majority of our study population expressed that their perception as they can perform the NG tube insertion with supervision in 2019 and 2020. There was a significant population of these prospective medical interns, the pre-interns, in 2021. They expressed their inability. They are unable to perform the NG tube insertion, but they had observed skill. Though we are expecting the though we consider this as an essential clinical skill before the commencement of the internship. Also, only less than 25% of pre-interns were confident in performing this clinical skill competently without supervision within all those last 3 years. Anyway, a small percentage of study population in each of these 3 years expressed that they are not only they were unable to perform the skill, but also had not even observed it. So our conclusions were, although the nasogastric tube insertion is an essential that is required to be competent, there is a considerable lack of perceived competency among prospective medical interns. So attention should be paid to improve the competency and self-confidence in performing essential skills like nasogastric tube insertion in all medical graduates prior to the commencement of medical internship. A hands-on preparatory program prior to internship may be beneficial in addressing these deficiencies in clinical skills and competencies. Though this can be interpreted as a simple analysis, we know about the fact July effect, which has been studied from some other countries like United Kingdom, who is the leader of good medical practice. The point which is highlighted from that July effect is the considerable downing of quality of healthcare practice at each and every starting point of new batches of doctors and also nurses. So I think it is not ethical to disregard any patient's life. So we can't simply disregard even a small percentage of lack in service. So we can recommend a mechanism to develop self-confidence and competency in performing clinical skills, including nasogastric tube insertion prior to the internship. If it is an essential, it will be good. Thank you, sir.
Thank you very much. Dr. Jayatissa, you have any comments?
Yes. Did you all calculate the sample size for this study?
Sir, actually, we didn't calculate the sample size. We usually send our questionnaire after collecting data from each and every faculty. For all pre-interns, we send this questionnaire. So, averagely, in 1 year.
To save time, I'll tell you. You know, this is a very large sample.
Yeah, sir.
You should not use large samples. You should calculate. If you are doing a scientific study, it is very important to calculate the minimum sample size, okay, right? Because when you collect data from such a big sample, there can be errors, so which affect the validity of your findings.
Yes.
This is too much, right? sample size calculation, then what else? The conclusion, you say attention should be paid to improve competency and self. So that this is not a conclusion. Conclusion you get from the findings, right? And the recommendation, more or less, they are the same, right? Yeah. And the font size of your slides could have been a little bigger than this, right? Yeah, because...
Yeah,
Thank
can
you,
I-
Dr. Jayatissa. Yes, Dr.
Can I
Preet.
come in? You see, good, very good, interesting stuff, but you know, pre-interns, there are a lot of pre-interns just going begging for jobs and being aimless. During that time, shouldn't it be used for a program for such things like, you know, all the skills training? And what about the skills training lab, Dr. Hanifa? Aren't they using in the as
we do, sir.
medical students?
Before we, there is a sort of a, before they start the internship, there is like a bit of a crash course which we do in the skills lab.
So this is also included?
It's not mandatory, or anybody who comes can come. Thank you very much. I hope, once again, may I remind you to take the young researchers to take the points that Dr. Jayatissa is saying about the study designs and so on. It will be very helpful to you. Thank you very much. May we congratulate the author. Next paper for this morning will be Study on Characteristics of Animal-Borne Diseases in Northern Naval Area by Samara Vikrama HDI and Samaratunga PO. The paper will be presented by Samara Vikrama HDI. I don't believe Dr. Samara Vikrama is here. So may we move on to the next paper, which is oral presentation number 12. Self-perceived competency in urinary catheterization among prospective medical interns of Sri Lanka in 2021. That is by Padiniya PSMV AB, Vijayaratna WHTP, Veerasinghe K, Hinatigala CSN, Vijayaratna NDSK, Nadishana WMVG, and Pereira MHMCNM. All right. The paper will be presented by Dr. Vijayaratna.
Thank you, sir. This is actually what my colleague presented previously. This is a similar one to that presentation. Today I am presenting on self-perceived competency in urinary catheterization among prospective medical interns of Sri Lanka in 2021. This is only considering the 2021 year, where this batch of interns, we have included medical graduates from local universities as well as from foreign universities. Urinary catheterization is a procedure used for diagnostic and therapeutic purposes, and it is considered an essential skill that is expected of a prospective medical intern. And the objectives were to describe the self-perceived level of competency in urinary catheterization among prospective medical interns of Sri Lanka in 2021, and we hope to explore the necessity of a preparatory program for medical graduates prior to the commencement of medical internship. And we were hoping to identify the necessary areas of content and strategies and methods of conduct for a preparatory program for medical internship. And considering the method we used, a descriptive cross-sectional study was carried out among 693 prospective intern medical officers in Sri Lanka in September 2021 using a self-administered questionnaire. This batch of pre-intern medical graduates are currently undergoing their internship, and they started their internship in October 2021, and we assessed the level of competency through a set of questionnaires which range from not being able to perform the skill and not having observed the skill to being able to perform the skill competently without supervision. Considering the results, among 693 study participants, all claimed to have observed procedure within their undergraduate period. However, only 91.2% of prospective medical interns were confident enough to perform urinary catheterization. This is with or without supervision, and among them, 61.8% were confident to perform urinary catheterization without supervision. However, the point I wanted to highlight is that although all the study participants claimed to have observed the procedure within their undergraduate period, 8.8% of them were not confident to perform the procedure. This is a matter of concern because in urinary catheterization is one of the most essential skills that is expected of a medical intern to perform without supervision, and here some of them have claimed that they are not confident enough to perform the procedure, which is this is a time period which was very closer to their commencement of internship. And the majority of 91.2% of prospective medical interns were confident in performing, and among them it is good that 61.8% were confident to perform urinary catheterization without supervision. So, in conclusion, the majority of the prospective medical interns were confident in performing urinary catheterization without supervision. However, a few were not confident in performing urinary catheterization despite spending many years as medical undergraduates. Hence, we would like to say that medical educationists may pay attention to formulating a mechanism that will enable all prospective medical interns to have hands-on practice to gain competence in important clinical skills, including urinary catheterization, before the initiation of their internship. And this is also, we did this study because of what my colleague said previously, the July effect, which will affect the patients when the intern medical officers commence their internship. So, thank you, sir.
Thank you very much for that presentation. I think the comments will come from Dr. Jayatissa. I think you'll learn a lot. Sir, over to you.
Nothing very much. Same problem with the sample size, 693, too much. Again, the results. They are given the percentages, and confidence interval should have been given. Right? That is, yeah. Majority of the prospective medical intern. The conclusion, I mean, just say the percentage who knew the procedure, who were confident in performing the majority, things like majority, I mean, there is no definition, right? In research paper, you can't say majority. Give the percentage. And of course, the observation, few had never performed urinary catheterization. That is not one of your objectives, right? Your objective is to assess the competency, perceived competency, right? And perceived level, yeah, in the other also this perceived level is not necessary, I think. Perceived competency, right? Yeah, okay, that's it.
And the same comment about your font, you need to. Thank you very much. Can we show our appreciation to the author for the presentation? There were two papers which were listed for presentation. So may I, in all fairness, just give them one more opportunity if they are there. Oral presentation number 8, self-perceived competency in intravenous cannulation by Nadishana BMVG. Right, so he's not there. And of course, oral presentation 11, study of characteristics of animal bone diseases in northern naval areas by Dr. Samara Vikrama. Right, so in the absence of those two, which should not be happening at this level of presentation, this is actually this is not very academic. When you have undertaken a paper to present, it is our duty to be here. So I don't think the college will accept this. In outer society, you might accept a lot of things, but let's try to maintain some academic standards. I know I'm not, the people who need to hear it are not here, but even for future people, it's considered a very serious offense when you do not turn up for a paper presentation, because we are publishing it and you might use it. So please be assured that we'll be writing to these gentlemen and ladies who presented the paper that they cannot include these papers in their publications or presentations. So as a chairperson of the scientific committee, I'll make it my personal duty to do so. And for you out here, please don't do things like this. I think to go into the wider thing, if you don't point out things which are, if you don't ignore things which are not happening correctly, you see the mess you get into. And I don't want to see Sri Lankan medical academia going that way. So please be assured that we'll be writing to these gentlemen. Thank you very much for all the other authors for your wonderful papers. They were very insightful, very scientific, most of them. You had gone through the process, the entire process of research. So thank you very much, and I'm very heartened to see that a lot of young researchers are continuing to present papers. So I thank Dr. Jayatissa for being my co-chairperson this morning. Any comments, sir, before we conclude?
It's encouraging to see that a lot of young doctors have enthusiasm in performing research. I commented only on the deficiencies, which is my duty. That doesn't mean that they are useless studies. I'm very happy to observe that these doctors have performed some sort of a study, right?
Can we do it now? Is it here? So may I call upon Dr. Jayatissa? I will read out the names for the presenters to come and please accept their certificates of presentation, and then we will conclude. So you can go there in front. Do this quickly. Right, so Dr. Patiratna, PASR, oral presentation number 1, a retrospective analysis of symptom course in a telemedicine monitoring clinic for acute symptomatic COVID in 2019. Dr. Patiratna, has she left? Right. So we'll see that she gets it. Thank you, sir. Oral presentation number 2, exploration of the timing of deliberate self-poisoning presenting to primary care institutions in rural agriculture, Sri Lanka, Dr. Pushpa Kumara. Yes. Dr. Pushpa Kumara, may I also ask you to accept the oral presentation number 4 for exploration of clinico-epidemiological predictors to redefine SAD person scale to identify deliberate self-poisoning risks in Sri Lanka. Thank you very much. The next recipient will be prevalence of polypharmacy and associated factors among elderly attending to the accident and emergency department in District General Hospital, Nagoda, Kalutara. The presenter was Dr. Dan Gampola. Thank you, Dr. Dan. Then oral presentation number 6, a series of child abuse cases which were admitted to a tertiary care hospital which could have been easily missed. Dr. Fernando, KMD. Oral presentation number 7, launch of HIV self-testing in Sri Lanka by Dr. P.S. De Silva. Oral presentation number 9, evaluation of knowledge, skills and attitudes and common practices among accident and emergency doctors for difficult intravenous access and use of ultrasound in selected tertiary care hospitals in Sri Lanka, Dr. A.G.T. Darshani. Oral presentation number 10, self-perceived competency in nasogastric tube insertion among prospective medical interns of Sri Lanka from 2019 to 2022, Dr. N.D.S.K. Vijayaratna. Oral presentation number 12, self-perceived competencies in urinary catheterization among prospective medical interns of Sri Lanka in 2021, Dr. W.H.T.P. Vijayaratna. Which was the satisfaction in primary care presentation in a tertiary care hospital, Dr. Gobi. Thank you, Dr. Jayathissa, for presenting those tokens. And we are 10 minutes late, so let me hand over to the next chairperson with apologies for being a bit late.